Imagine going to a clinic for, like, a simple 30-minute cosmetic tune-up, right?
Yeah, just a quick fix.
Exactly. But only to discover that the procedure permanently trapped you inside your own body's pain response.
Which is a terrifying thought.
It really is. You walk in hoping to fix this vague sense of discomfort, and you walk out with a condition that makes physical intimacy, medical exams, or honestly, even just sitting down physically agonizing.
Right. And that is a reality for countless women who end up confusing a complex neurological reflex with, well, a structural need for cosmetic tightening.
Welcome to today's deep dive. We're unpacking a highly stigmatized and, frankly, frequently misunderstood area of women's health.
We really are. It's a diagnostic minefield.
We're looking at the booming market of vaginal tightening treatments and specifically how those treatments collide with a severe involuntary pain condition known as vaginismus.
Because when you look at the recent clinical guidelines alongside honestly, the terrifying case studies emerging in medical literature, a very dark paradox emerges.
Yeah, the treatments designed to quote-unquote rejuvenate tissue are actually accelerating the damage.
Exactly.
So we've pulled together a massive stack of medical documentation to really get to the bottom of this. We're looking at official protocols from the NHS, safety warnings from both the FDA and the UK's National Institute for Health and Care Excellence, or NICEN, curriculum data from the American Urological Association.
Which is a lot of ground to cover.
It is. But our core mission for this deep dive is to answer one crucial question that constantly gets buried in all the clinical marketing.
Right. And that question is, should vaginismus be treated before a patient undergoes any vaginal tightening procedure?
Okay, let's unpack this, because before we can even look at the lasers and the surgeries, we really have to understand what vaginismus actually is.
Right, because the biological mechanics of it totally explain why patients are getting so tragically confused.
So how is it defined in the literature?
Well, vaginismus is defined medically as an involuntary spasm or tightening of the pelvic floor muscles. Specifically, this happens in the outer third of the vagina, usually in anticipation of penetration. And, the critical element to understand here is that word involuntary.
So it's not a conscious tensing of the muscles.
Exactly. It's not on purpose. It's an automatic, deeply ingrained nervous system reflex. For someone suffering from this, inserting a tampon, undergoing a routine cervical smear test, or attempting penetrative sex becomes excruciatingly painful.
Or just physically impossible.
Right, exactly.
And the clinical texts draw a line between two different types, right? Like primary and secondary.
Yeah, so primary vaginismus means the patient has never, at any point in their life, been able to experience painless penetration. The reflex has just always been there.
Okay, and secondary?
Secondary means it develops later in life, often after years of completely normal, pain-free function.
And the triggers that prompt the nervous system to create that reflex are pretty vast.
Oh, hugely vast. They can be structural and physical, like, say, a severe bout of thrush, a chronic urinary tract infection, or the acute trauma of a difficult childbirth.
So the body experiences localized pain and basically decides to lock down the area to prevent further damage.
That's it, exactly. But, the triggers can also be entirely psychological.
Right. I mean, past sexual trauma or assault would obviously trigger a massive protective response from the nervous system.
Absolutely.
Yeah.
The trauma physically encodes itself in the muscle memory, but it doesn't even have to be direct physical trauma.
Wait, really?
Yeah, a profound fear of pain, or even growing up in an environment with a very strict, punitive view of sex where intimacy is framed as shameful or dangerous, that can do it too.
Wow.
The brain internalizes that profound shame or fear, and the physical manifestation of that is the pelvic floor clenching like a fist to protect the body from perceived harm.
I found an analogy in the Greater Manchester NHS clinical guidance that completely shifted how I view this.
Oh, the driving one.
Yes.
Yeah.
They compare having vaginismus to driving a car down the highway while gripping the steering wheel incredibly tightly without even realizing it.
It's such a good way to visualize it.
It is. You still have control of the car, you are getting to your destination, but you are unnecessarily exhausting your own body. Your muscles are holding this massive amount of tension around the clock.
And that chronic exhaustion completely alters the patient's perception of their own anatomy.
How so?
Well, a hypertonic or overactive pelvic floor doesn't always just register in the brain as acute pain. Often the brain interprets that constant muscle fatigue as a heavy pelvic pressure.
Like a general vague discomfort that just won't go away.
Exactly.
But wait, If the muscles are physically exhausted from being too tight, how does a patient arrive at the conclusion that they need vaginal tightening? I mean, that feels like a complete contradiction.
It is a contradiction, but think about the pervasive societal messaging women receive about their bodies, right? Especially as they age or after they have children.
Oh, sure.
The overarching narrative is that the pelvic region inevitably loses its elasticity. Society tells women that their bodies are becoming, quote-unquote, loose.
Right, so a woman feels this persistent heaviness and discomfort from muscles that are actually burning out from chronic spasming.
Yes, and she misdiagnoses herself. She thinks, I've had a baby, things feel heavy and different down there. I must be suffering from laxity.
So she attributes a complex functional neurological muscle spasm to structural looseness.
Exactly. And because she thinks the core problem is structural looseness, she naturally seeks out a structural fix.
Which brings us to the technologies themselves. If you're listening to this and wondering how a doctor fixes perceived laxity, the options sound like something out of a science fiction novel.
They really do. The clinical literature broadly categorizes the non-surgical options as EBD's energy-based devices.
Right, so we're talking about fractional CO2 lasers, erbium lasers, and radio frequency devices.
And the underlying mechanism behind every single one of those energy-based devices relies on a biological process called thermal necrosis.
Which is wild because you read the brochures for these clinics and they use words like rejuvenation and revitalization, but thermal necrosis literally translates to tissue death by heat.
Yeah, it's a rebrand of a very aggressive process. They are inducing controlled burns deep within the vaginal epithelium.
Why would burning it make it tighter?
The logic driving these treatments is the body's natural wound healing cascade. By intentionally causing microdamage to the deeper layers of the tissue, the immune system is tricked into a state of emergency.
Okay.
So the body rushes fibroblasts to the site of the burn to repair the damage, and those fibroblasts lay down dense new bundles of collagen and elastin.
Which ultimately thickens and firms the tissue as it heals.
Exactly.
And if the laser isn't aggressive enough, the sources also outline surgical vaginoplasty.
Right, which is much more invasive.
Yeah, that requires general anesthesia. A surgeon physically excises excess vaginal lining and aggressively sutures the pelvic floor muscles closer together to artificially narrow the canal.
And both of these paths, the thermal burns and the scalpel, are fundamentally altering the architecture of the tissue.
Which is why regulatory bodies have been desperately trying to pump the brakes on this entire industry.
Oh, absolutely. If we look at the July 2018 mandate from the FDA, they issued a severe public warning explicitly stating that energy-based devices are not approved for vaginal cosmetic procedures.
And the ICE guidelines in the UK echo this exact alarm. They state unequivocally that the long-term evidence for the safety of these devices is grossly inadequate.
So the marketing has completely outpaced the actual science here.
Totally. Now, the clinical documents do mention that these lasers have a legitimate medical application, right? Like for treating severe menopausal atrophy when estrogen therapies fail.
Yes, there is a medical use case, but clinics are selling them as a lunchtime cosmetic tune-up for anyone feeling a bit, loose.
Right, and the lack of stringent diagnostic screening is where the true danger lies. Clinics are heavily marketing a solution for laxity without checking if laxity is actually the problem.
And here's where it gets really interesting. If a patient has that heavy, exhausted feeling from an undiagnosed vaginismus spasm, and a doctor simply points a laser at the tissue without investigating the underlying muscles, what actually happens?
Well, we can look directly at the case studies documented in the PMC source data, and the clinical findings are horrific.
They really are.
They documented women who underwent laser vaginal tightening to fix perceived laxity, but the laser treatments obviously failed to resolve their discomfort.
Because the root cause was an undiagnosed pelvic floor spasm. The tissue wasn't the issue.
Exactly. And when these women eventually required corrective surgeries, the operating doctors found that the vaginal mucosa had been fundamentally destroyed.
Yeah, the tissue had become rigid, deeply scarred, and friable.
Friable meaning the tissue was highly delicate, easily torn, and prone to spontaneous bleeding. The laser essentially replaced healthy, flexible mucosa with a wall of rigid scar tissue.
It's devastating. The NICE safety reports detail cases where patients developed persistent and progressively worsening dyspareunia.
Which is the clinical term for agonizingly painful sex.
Right. They documented a 68-year-old woman who developed a crescent-shaped fibrous band right across the middle of her vagina that created a literal obstruction.
An obstruction, that's insane. And another patient developed massive systemic pelvic floor hypertonus, after the laser treatments.
This represents a catastrophic failure of diagnosis.
Hmm.
Vivek Nama, a consultant gynecologist referenced in the clinical protocols, states that screening for pelvic floor abnormalities and vaginismus is an absolute non-negotiable prerequisite to any treatment.
So let's break down the exact biological collision happening here. If the muscle is violently clenching because the nervous system is terrified of penetration, and you use a laser to turn the flexible skin above that muscle into rigid scar tissue,
Yeah.
isn't that like putting a straitjacket on someone who is having a full-blown panic attack?
A straitjacket is an incredibly accurate way to visualize it. You aren't calming the nervous system down, you are just trapping it. Energy-based devices in surgical vaginoplasty only treat the superficial tissue. They do absolutely nothing to address the hyperactive muscle spasm underneath. You are essentially shrinking the wrapping paper, but the box inside remains totally crushed.
So if the skin is tightened and scarred over a muscle that is already clenching, what happens the next time that patient attempts penetration or goes in for a medical exam?
Well, the tightened, scarred skin has lost its elasticity. It physically cannot stretch to accommodate the spasming muscle, so it tears, it burns.
Oh.
Yeah, the patient experiences acute, searing physical trauma.
And then the brain receives a massive flashing red alert signal that penetration truly does equal severe physical damage.
Exactly. That is the exact neurological feedback loop we see in the clinical data. The brain panics. It sends an even stronger, more violent signal to the pelvic floor muscles to lock down the perimeter.
So the vaginismus spasms escalate exponentially.
Right. The new, entirely manufactured pain from the cosmetic procedure permanently validates the brain's original misguided fear.
That's so tragic. The practitioner has basically taken a highly treatable muscle spasm and permanently sealed it behind a wall of unyielding scar tissue.
It shifts this from a simple misdiagnosis into a scenario where the medical intervention is actually mutilating the patient.
And the clinical consensus leaves absolutely no room for debate on this, right?
None whatsoever. Vaginismus must be accurately diagnosed, and it must be comprehensively resolved before a practitioner ever considers altering the tissue. Treating the spasm is the mandatory first step.
Okay, so we know that blasting the area with lasers to induce thermal necrosis is the absolute worst possible approach. How do you actually get a muscle that is locked in a state of neurological panic to finally let go?
The entire therapeutic philosophy for vaginismus is the diametric opposite of tightening. The protocol is built entirely around relaxation, desensitization, and neuroplasticity.
And the sources outline a very conservative, evidence-based roadmap that starts far away from any surgical tools.
Yes, the front line is pelvic floor physiotherapy combined with cognitive behavioral therapy.
Because the condition exists at the intersection of the physical and the psychological, the treatment has to address both simultaneously.
Exactly. A specialized physiotherapist utilizes biofeedback to teach the patient how to consciously locate and release the tension in their pelvic floor.
They are quite literally teaching the nervous system how to let go of the steering wheel.
That's a great callback, yes.
Ugh.
Meanwhile, the cognitive behavioral therapy addresses the psychological root of the trauma, helping the brain uncouple the association between intimacy and danger.
And a major tool they use to rebuild that physical trust is vaginal trainers or dilators.
Right.
Reading through the NHS Lothian guidance, this requires immense patience. The trainers are smooth, medical-grade objects that come in a graduating series of sizes.
And the patient always starts with the smallest possible size, working in a completely safe, controlled environment.
So it functions as systematic exposure therapy for the nervous system.
Yes. By gently inserting the smallest trainer, the patient is carving new neural pathways. They are proving to the brain, in real time, that penetration can occur without triggering a pain response.
Slowly dismantling the biological alarm system over weeks or months.
Right. Once the nervous system normalizes the smallest size without spasming, they graduate to the next. It restores complete autonomy to the patient.
I'm stuck on the exposure therapy aspect for the most extreme cases, though. If the muscle spasm is a completely involuntary locked door reflex, how do you even get the smallest trainer in there to begin the therapy without instantly triggering the panic loop and tearing the tissue?
That's a really important question. The American Urological Association curriculum details a specific medical intervention for those severe grade 4 cases where the pelvic floor is entirely impenetrable.
Okay, what do they do?
Clinicians utilize botulinum toxin injection.
Botox. Like the same neurotoxic protein used to smooth out facial wrinkles?
The very same. But in this context, it is deployed deep into the spasming musculature of the pelvic floor.
Okay, how does that work mechanically?
So Botox works by cleaving specific proteins at the neuromuscular junction, which completely prevents the release of acetylcholine.
And without acetylcholine, the muscle fibers simply cannot contract.
Exactly. It chemically forces the pelvic floor to relax.
So it serves as a chemical override to the brain's panic signal.
Right. It creates a temporary window, usually lasting 3 to 4 months, where the muscles are physically incapable of spasming.
Oh, I see. So during that critical window of paralysis, the patient can actively engage in pelvic floor physical therapy and utilize the dilators without experiencing the agonizing pain that previously triggered their fear response.
Yes, it shatters the pain loop long enough for the brain to learn a new, pain-free baseline. And once the Botox wears off, the newly trained neural pathways remain.
That is fascinating. If you are listening to this and wondering how a patient is supposed to navigate this landscape, the sheer irony of the situation is staggering.
It really is.
A patient walks into a clinic desperate for relief, asking for a 30-minute laser treatment to fix a complex functional issue, hoping the technology will serve as a magic wand.
But the real solution, the only scientifically valid path to healing, involves no lasers, no burning, and no instant gratification.
Right. It requires a slow, deliberate retraining of the brain's deepest survival instincts. What stands out to you about all this?
I mean, it exposes a fundamental truth about how human physiology operates under duress. Vaginismus is not a mechanical failure of the body. It is the body acting in a hypervigilant, highly protective manner.
It is a defense mechanism running on overdrive to shield the host from perceived trauma.
Exactly. And healing requires profound respect for that defense mechanism. You have to patiently dismantle the alarm system through desensitization and therapy.
Because if you attack the physical structure with a laser to force it into submission, the nervous system will only fight back harder, creating more scar tissue and more pain.
Right. Proper assessment, deep biological knowledge, and patience are the only tools that actually work.
Well, we've unpacked a massive amount of clinical data today to cut through the marketing noise. The core takeaway is that vaginal laxity, the sensation of structural looseness, and vaginismus, a severe neurologically driven muscle spasm, are two entirely distinct conditions.
Conditions that are tragically confused by both patients and reckless practitioners.
And that widespread confusion elevates proper medical diagnosis to the single most critical step in the entire process.
Because if a clinic fails to identify the underlying spasm and instead subjects that exhausted muscle to lasers or surgical sutures meant to shrink the tissue, the consequences are devastating.
The patient is left with rigid scarring, amplified spasms, and a vicious cycle of pain that literally feeds on itself. The medical mandate is crystal clear.
Yeah.
You must treat the spasm before you ever consider treating the tissue.
It really demands that we actually listen to the complex signals our bodies are sending us,
Yeah.
rather than immediately seeking out a cosmetic fix for a feeling of heaviness.
Absolutely. I want to leave you with a final thought to ponder, something that really struck me as we combed through the mechanisms of this condition.
Yeah.
The human body has an astonishing capacity to store psychological trauma and fear directly inside its musculature.
It really does.
The fact that our ultimate protective reflex against pain locking a muscle down completely is exactly what ends up generating the most severe chronic agony for the patient is a profound biological paradox. Our survival instincts can so easily become our own prisons.
That's a powerful way to look at it.
It makes you wonder how much of the physical pain we experience in our daily lives, like the relentless tension we carry in our shoulders, the unconscious clenching of our jaws, the heavy pressure we drag around with us, is actually just a physical manifestation of a protective instinct we no longer need.
Something to think about.
Definitely. Thanks for joining us on this deep dive.